So in one of the previous videos, I mentioned how to do a psychiatric interview, or the basics of a psychiatric interview. And this video will talk about other ways that a psychiatrist will assess or evaluate the patient that's in front of. So psychiatric assessment is a little bit different than a medical assessment in that we really don't use a stethoscope in our time with patients. So for the most part, you don't really need that. It is important though to sit in a chair or try to be at eye level with the patient so that you don't come off as too intimidating or too powering, etc. So the previous video did talk about many different sections of the psychiatric interview, and this mental status exam is just one part of it, although it's really important, which is why I sort of dedicated this whole other video to it, because there's a lot of nuances or intricacies about it where, if caught upon, it can help you to gauge what the patient or what the person in front of you may be going. Some major subsections of the mental status exam that really do need to be talked or highlighted upon. First is their appearance. How does the patient look? Are they wearing clean clothes? Are they dirty clothes? Do they have an odor to them? What's their eye contact like? Are they making eye contact? Are they not making eye contact? All that can give us clues to what they may be going to. Also, their mannerisms or their motor behavior. Are they moving a lot? Are they fidgeting? Do they have a hard time sitting still? Are they moving too much or too little? What's their attitude like? Are they being cooperative or are they not cooperative? Are they being aggressive or are they a little bit hostile? Would you say they're pleasant or not so pleasant? At some point in the interview, it's important to ask them how are they feeling, and this is in the patient's own words, and you can actually put this under quotes when you're writing up the note, because that's how they're feeling. And then that's different than the affect. The affect is, how do you as a clinician perceive how they're feeling? Is it congruent with their mood? If they say they're feeling happy and good, do they appear to be happy and good, or are their eyes like very down on the ground, they're not making some eye contact, and do they look depressed or scared? So be as descriptive as their speech like. Do you notice any changes in their tone of voice? Are they talking very fast or really slow? Is the volume high, low, or normal? All of these can give us clues to what's going on. During the interview, did they appear to be like looking around the room or talking to things that aren't there, or seeing things? Or hearing anything unusual during the interview? That can all suggest something's wrong with their perception. Thought content is, was there any predominant theme or focus that they were talking about? Or they focused a lot on their medical problems, or focused a lot about some event or people which maybe didn't seem that important in the history taking that you gathered? What was their thought processes like? Were they answering the questions as you were asking them, or did they seem to go off on tangents? How about their sensorium? Did they appear to be alert on interview? Were they sleepy? Did they know where they are? Did they know how they got there? What was their memory like? You can actually ask some specific questions to test your long-term memory, especially if they're in the United States. What are the last 4 presidents of the United States? Or do they recall what happened on 9/11, 2001, if they're old enough to recall that event at that time. Also, another way to assess memory is a short-term memory. You give them 3 objects to recall and ask them what they are in about 5 minutes. So I usually do the same 3 objects. I just do apple, honesty, car. Can you repeat those for me? Apple, honesty, car. Alright, hold those in your memory about 5 minutes. I'll ask you what they are again. And so after 5 minutes pass, I ask them what were those 3 objects. And I give them clues. If they maybe identified 1 or 2 of the 3, I give them a clue for the third one, or the second one I give them either multiple choice, or okay, if they missed car, it started with the letter C, or it's a type of transportation mode. Some ways to test their concentration. There's a few ways. One, if they have pretty decent mathematical abilities, and one way you could assess this by their education level. You can ask them to subtract 7 from 100 and keep doing that consecutively. So they go from 100 to 93, 86, 79, 72, 65, etc. If they're not really that good at math or haven't been in school for a while or something, you ask them to do the days of the week backwards to assess their concentration, or you can ask them to spell world backwards. So days of the week, Sunday, Saturday, Friday, Thursday, etc. World. First have them spell it forward so that you know they can spell it W-O-R-L-D, and spell it backwards, D-L-R-O-W. It's also helpful to comment about their fund of knowledge or about their intelligence based on the conversation. Did it seem like it was adequate or not adequate? Also, their judgment. Do they seem to know the consequences of their actions, and are they able to act accordingly? And usually this is similar to what their insight is, or insight, another word for insight is how much understanding do they have of their illness. Those are the major categories to identifying the mental status exam, and it's good to comment on all of them and pertinent positives and pertinent negatives because it can help support what you think they're going through. For example, in general appearance, if they appear unkempt or disheveled or malodorous or something, that could be considered to be signs of a cognitive disorder, maybe a psychosis or severe depression. If they have pinpoint pupils, that could be side effects of narcotic use. Or if they're not making eye contact at all, that could be depression, it could be paranoia, or they may have a difficulty trusting people or suspiciousness of people, like what can be seen in post-traumatic stress. So their motor behavior, is it a lot? Are they very active or increased motor activity? That can be a sign of depression, bipolar, ADHD. Maybe it's drug abuse such as stimulants. Is their motor activity decreased? That could also be a sign of depression. Are they having any shakes or tremors? This could be side effects of long-term use of lithium or antipsychotics, or could also suggest anxiety. Their attitude, like during the interview, are they very hostile? That could be a mood disorder or personality disorder, or could maybe be intoxication or withdrawal from drugs. Again, are they suspicious of you? That could be paranoia or post-traumatic stress. Or are they just indifferent or apathetic? That could be a sign of conversion disorder. That could also be depression, or again, substance abuse or withdrawal in particular. Did they describe their mood? Did they say they were depressed, happy, anxious, angry? Some things, if they're happy or elated, you may want to consider bipolar, depending what they're seeing you for. If they're angry, that could also be bipolar. It could also be related to anxiety. It could be also related to post-traumatic stress. Affect. Remember, this is how they appear to the clinician. Were there frequent changes in their mood? Were they laughing at some points in the interview and then crying at other parts? That could be emotional distress, maybe from drugs or maybe a personality disorder. Did they have no emotions at all? Some terms like for flat or blunted or constricted can be in schizophrenia. Their eye contact, is it sparse? Were they not making eye contact? Again, that's paranoia or PTSD perhaps. And then if they were tremulous or shaking a lot of times, maybe they're uncomfortable, maybe they're anxious, maybe they're scared. What was their speech like? Were they talking very fast where you couldn't get a word in and it was hard to slow down what they're saying? They could be, again, anxious or scared, or even pressured speech from bipolar disorder. Were they talking very slowly and it was kind of soft tone, you couldn't really understand them? That could be also depression or psychosis. Or was their tone very irritable and they were just wanted to hurt someone, or that could suggest some anger? Or were they talking very loudly? Maybe you know this in hearing issues or bipolar. Maybe it's someone who is just attention seeking. And then we ask, or you sort of get the sense about perceptual disturbances. You can actually ask, are they hearing things unusual or seeing things that other people don't see? If there's actual sensory stimuli there that are misinterpreted, that could just be an illusion. But if there's no sensory stimuli causing it, that would actually be a hallucination, and it can happen with any of the five senses, with hearing, with vision, with smell, touch, or taste. Thought content can be affected in some medical symptoms or conditions. For example, if they're anxious or they have a lot of concerns about their medical stuff, that could be anxiety or somatic symptom diagnosis. If they're focused on a particular person or event, that can happen in a delusion. If it's something unrealistic, that could be some other form of psychosis. or conspiracies like the government or people are conspiring against them. That could just be a sign of paranoia. You know, what were their thought processes like? Were they answering the questions normally? Usually we'd say they were linear, their thoughts were organized. Were they not able to answer the questions in an organized fashion? We could say nonlinear or disorganized. That could be in psychosis, cognitive disorders, maybe anxiety or personality. Did it take them a while to answer the question? So circumstantial is like a circle. Did they talk about something else and then come back to the main topic? That could be a sign of anxiety or maybe psychosis, or just if they missed the mark directly, they went off on a tangent. It could be anxiety, psychosis, personality disorders, even bipolar. In bipolar, you get this notion of flight of ideas. You go from one topic to another, and it just keeps going to these like sort of under sensorium. So do they know where they are, their name, what the date is? If any of these are off, it can be suggestive of a delirium, which can be seen quite often in hospital settings. It could be cognitive disorders such as dementia, maybe it's schizophrenia or other psychotic disorder. Maybe they have just intellectual disability or limitation, or acute intoxication or withdrawal from some sort of substance like alcohol, stimulants, heroin, something like that. Problems with long-term memory can be seen in cases such as dementia or neurocognitive disorders. There's also a condition with chronic alcohol use where people lie and make up stories, and it's called confabulation. Can also be seen in these Wernicke's encephalopathy, where it's related to long-term alcohol use, damages parts of the brain, and impacting patients' memory and leading to things like early dementia often. Immediate or short-term memory, recall that we asked them to do the 3-object recall after 5 minutes. In cases of acute anxiety or depression, these can be affected. It can also be in cognitive disorders, or assessing their concentration through the days of the week or serial 7s. That can also be affected in depression, anxiety, or cognitive disorders. And these are actually good to monitor over time. If you feel like someone's going through acute depression or acute anxious state, and it improves, their depression or anxiety improves over time, then you could find that maybe their short-term memory also will improve over time. Again, it's important to make a note of their information that they're processing or their fund of knowledge. If this is adequate, great. If not adequate, it could suggest a cognitive disorder, maybe cognitive symptoms from chronic schizophrenia, or maybe intellectual disability. Judgment can be impaired for various reasons. Maybe it's drugs, maybe it's intellectual limitations, maybe they have brain disease or schizophrenia, and usually this coincides with insight or the understanding of the disease. Again, the same conditions can affect insight. Also, insight can be impaired by any delirium causes, or really any severe mental illness can impact insight. So I hope you guys enjoyed this sort of introduction about the nuances of a mental status exam and what the psychiatrist looks for in a clinical encounter. You know, you could try to use this in any of your social interactions to see, try to gauge what the other person may be going through.